It's a considerable honor to be here, especially on a stage with people I've admired my whole life. In any case, I wanted to talk about an issue which is pressing in Mexico and is also pressing in many parts of the world where there is a right to health care or right to health in the Constitution. Because I want to talk a bit about the role of the courts and the health system in addressing the notion of a right to health. To clarify the role of the courts and the health system in progressive realization of a right to health, or more narrowly, health care, we must first understand what such a right is and what its entitlements are. In my view, the justification for a moral right to health and health care lies in a theory of justice. Such a moral right can be embodied in a constitution where it becomes a legal right with similar entitlements. The recognition through treaties and international covenants of a human right to health or health care also makes excuse me, I've lost my place. Also makes the entitlements of such a right progressively realizable in light of reasonable resource constraints. And my picture is that there are always resource constraints, some more reasonable than others, but we can't avoid that problem because healthcare in health is not the only good that a system or a society has to address. And when we try to invoke resources and use resources to promote health, we have to think about these other goods as well. So in my view, the central goal of health policy, which I know Dr. Frank will talk about, are to promote population health and distribute that health fairly. This involves the progressive realization of a right to health. I do want to say one word in beginning on the notion of distinguishing a right to health from a right to health care, because no doubt the philosophers in the room will jump on my back for talking about a right to health. What I've been persuaded by is that health has many determinants, and I believe the fair distribution of those determinants is a social obligation, giving rise to the right to health. Some determinants of health keep us healthy by reducing the risks of ill health, such as traditional public health measures and a fair distribution of the social determinants of health. Medicine, in contrast, aims to keep us healthy once we are sick, though it too can provide some prevention for various kinds of illness. So access to health care is also a right, on my view, because there is a right to health. Of course, saying we have a right to health does not mean that if we get sick and die, then our right to health has been violated. It only means that the fair distribution of the factors the society can control is something that we have a right to. A right to health or health care, I have elsewhere argued, is a special case of a right to fair equality of opportunity, and I won't repeat those arguments here. This conception of a right to health or health care starts with the assumption that we have a right to fair equality of opportunity and that protection of our health makes a significant, if limited, contribution to the preserving of those opportunities. So we can think of a right to health care as an implication of a right to fair equality of opportunity. How a society invests resources in meeting its obligations to protect population health and distribute that health fairly, the goals that sometimes conflict, matters greatly. Yet there will be reasonable disagreement about how to allocate resources to that task. Each resource allocation has an opportunity cost that must be considered. Specifically, every treatment that is provided can be replaced in this allocation by treatments for other conditions, each of which has other claimants for care. If we provide one treatment, we cannot provide the others. At least I'm assuming that. These are the opportunities we miss because we can assume we can provide one treatment. We have to make sure that the treatments we provide do not displace more important treatments that we could provide. Even if some intervention would cure an individual of a condition, his or her right to health or health care does not imply that that treatment is owed to that individual if the opportunity cost of providing it is too great. Perhaps other claimants to health care should be treated instead. A plausible claim is that an individual has an entitlement to a treatment if it is something that a healthcare system fairly decides to include in the array of services it offers to all in need, given its constraints on resources. And some individual claims to treatment will not be among those in such an array. Since reasonable resource limits mean that not everything can be done for everyone in need, the progressive realization of a right to health means that we cannot deduce that a specific treatment for a specific condition is an entitlement of that right unless the treatment is part of an array of services that the system concludes all must have access to. Accordingly, a constitutional right that is progressively realized carries with it only those entitlements as well. So too, I argued, does a human right to health or health care that is progressively realized. Of course, the idea of progressive realization can become a disguise for a state unwilling to realize a right to health and health care, and it has often been served in that role. But the idea behind progressive realization is sound, even if the concept is often abused. With limited resources, we cannot do everything that we could do with more resources, and so we must progressively realize a right. This view of the relationship between a constitutional right or a human right to health or health care and the entitlements such a right involves has implications for the role of the courts and of the health system. Specifically, the courts should not conclude that a right to health or health care means that any and every effective treatment, regardless of cost, is something that people with that right are entitled to. To decide that a specific treatment is an entitlement or a right to health or health care under reasonable constraints, a court would have to determine that the opportunity cost of providing that treatment is similar to the opportunity cost of other treatments in the health system does include. Properly done, that is a task and a responsibility of the health system, since it, not the courts, is in a good position to judge the opportunity costs of treatments it includes, which doesn't mean that health systems always do a good job of that. They often do not. The task of a health system is to implement a fair, deliberative process through which decisions about the inclusion of new treatments are made. The courts should show appropriate deference to the obligation to this task to the health system, but it has the responsibility to make sure that there is progressive realization of a right to health or health care. Herein lies both the threat and the promise that we hear about as the judicialization of the health system. I hope I don't have to say that word too many times. Judicialization poses the threat of encroaching on the proper task of the health system, which must use limited resources to both promote population health and yet to distribute that health fairly. And this means treating all as equal possessors of a right to health or health care. Specifically, the fear is that the courts will undertake a task they cannot perform well, namely the judgment that the opportunity, about opportunity costs of treatments which I'm assuming they cannot perform well. Moreover, this risks increasing inequalities, not reducing them, since better off individuals usually have more access to the courts than worse off individuals. At the same time, there is a promise of benefit. since the courts may counter the power of vested interests and political lobbies to entrench or even increase health inequalities. I think there is a middle ground between the threat and the promise. It involves both the health system and the courts acting in a way that improves the progressive realization of a right to health or health care. The health system must better integrate different components of the health system and arrive at a more uniform set of decisions about the fair allocation of resources, so that the different groups in the population all enjoy the contingent entitlements that the right to health care or health provides. This requires establishing, I think, a fair deliberative process for making those resource allocation decisions. Neither the integration nor the implementation of that kind of a fair deliberative process is easy to do, but neither is it impossible to do. On the other hand, the courts must focus on judgments that have the prospect of reducing health inequalities while progressively realizing a right to health. Not only does this mean taking steps to decrease existing inequalities in access to the courts, but it means showing due deference to the delegated authority of the health system to make opportunity cost judgments in a fair and deliberative fashion. But showing due deference to a fair deliberative process requires that there is a process to which deference is owed. If equity across parts of the health system requires integration, including a fair process for resource allocation decisions across these different components of the health system, then there has to be a real attempt at integration to evaluate and show deference to. Due deference to that process should also mean that rationales the process generates should be consistently applied. The courts can make sure that the right to health and health care is respected. I see these slides are flashing by, but I'm not controlling them, so I don't know what's happening, and I haven't been paying attention to them. Any case, thank you, whoever's doing that. Due deference to that process should also mean that the rationales in the fair deliberative process should be consistently applied. The courts can make sure that the right to health and health care is respected equally for all people through oversight of the fair deliberative process implemented by the system. In previous work, Jim Sabin and I developed a theoretical justification for various conditions that we think a fair deliberative process should meet. As long as you're flipping through these slides, go to the next one. Thank you. This very abstract account of what a fair deliberative process involves is something that in previous work under Dr. Frank's supervision in part when he was Secretary of Health in Mexico up until 2006, and with Eduardo Gonzalez Pierre's assistance. I didn't realize Eduardo was going to be the moderator for this session, but it is very nice to see old collaborators together in this setting. In 2006, we constructed a manual to adapt the approach to decision-making that we described, Jim Sabin and I described in a very abstract fashion, to the catastrophic insurance plan in Mexico. And the intention behind that was to use this as a test of a particular adaptation of a deliberative process in making the kind of decisions about expanding the resource allocation to new diseases in the catastrophic insurance plan that there was no good model for anywhere in the world. We constructed this manual, and it adapted, divided the task into different groups for different participants. There was a clinical group, an economics advisory group, and this is a flow chart depicting that. So the clinical and economics groups would work together on particular disease conditions, present a recommendation to an ethics group, which would make some recommendations, or they would present information to the ethics group. The ethics group would make recommendations, and these would be vetted by their social acceptability. It turns out that in the subsequent administration after Julio Frank's, this process was not actually fully implemented, and one of the main obstacles was that there was a lot of resistance to the social acceptability component. What exactly did it mean? How could one manage those groups? How do you prevent social acceptability judgments from turning into lobbying efforts by vested interests? So that's an issue that I think has to be worked on further, and will be. So this manual was constructed to test the idea of, could this very abstract idea of a deliberative process be adapted within the framework of the Mexican laws that regulated the catastrophic insurance plan. Since that time, many decisions have been made about what diseases and conditions to add to the catastrophic insurance plan. And these were not made with the benefit of this process. So my suggestion is that it is not too late to introduce an adaptation or a revision or reconsideration of this process into the Mexican system. And if it did, it could become a model for integrating many pieces of the healthcare system in and the benefit plans they offer in Mexico. So I'm making a policy recommendation based on some background bioethical thinking about the considerations that would determine whether judgments are made in a fair and legitimate fashion. This is a proposal that is now under consideration and review by the Mexican system. So it is something that I hope could illuminate what the task of the Mexican health system is, but also set some limits on what the role of the courts would be. Because if this manual is implemented, I think that there is something for the courts to show due deference to and to show some clear respect for, namely an honest effort to make fair decisions about the resources, uses to which these can be put in protecting people against the financial burden of these diseases. I wanted to make a final remark about bioethics, because the picture I have, and it was somewhat foreshadowed by Tom Beecham's remarks, that bioethics was born and raised, and as many people have noted, and it was rooted in the dyadic relationship between doctors and patients, or researchers and subjects. And it was also focused on the question, should we do everything we're able to do using new technologies? What I'm proposing then is that bioethics focus as well on whether health systems and courts are functioning in a way that promotes population health while distributing it fairly. So this I take to be an exercise in the bioethics and health policy that focuses on population health. Perhaps That's because I now work in, under Julio Frank in a school of public health, that I've come to think about this as the central feature, that direction that bioethics should move in. My claim is that this effort to pursue the two goals of health policy, distributing health fairly while at the same time improving population health, it requires a concern about prioritization of how we use our resources, and that's what I've been addressing. Bioethicists, in my view, must think about how we can best use our resources to accomplish these two goals of health policy. And they have to do this for populations, and they have to train more people to help them achieve those goals. Thank you.